Right.
So I know that some of you, this is not, probably most of us aren't used to looking at these things on a normal basis, unless you're used to doing normal like graphics and things. So some of these graphics actually are available on the Hamilton, which we'll kind of get into. So what do you think the importance of monitoring graphics are? They actually tell you a little bit more about your patient before you even get started. So if I'm starting to see a secretion change, so my resistance is actually increasing, I'm actually going to see it on my graphic waveform way before I see the numbers kind of start coming through. So there's a lot that you can actually start looking at before. So so I know, yeah, this one I apologize, it is a little on the fuzzy side. This was actually made to be in a darker environment, but so one of the things there was an Oxford study back in 1977 by Hack and Mead, and what they evaluated was the typical types of ventilation that we actually are doing on a normal basis. So, pressure control, volume control. So what they found is when those compliance things happen, so you'd have a nurse that goes in a room, they give a sedative to a patient that might be extremely active. So all of a sudden now their CO2 drops or increases, and now all of a sudden we go in, we make some volume or rate changes. So now we're already affecting the lung. So then before long, they're going from a 500 tidal volume up to 1,000. So the recruitment part of that lung is now extremely damaged. So this waveform actually you're looking at as a PRVC type waveform, which one of the concepts of ASV is almost exactly like that, because you're going to be utilizing a guaranteed minute volume versus just a volume by itself. So I'm not going to say I'm going to give you 500 cc's and that's going to be guaranteed, okay? But you're going to be doing it that way. So if you look at after the fourth loop and on the waveform, so you have three different waveform patterns here. The first one basically is flow, pressure, and this is tidal volume. So after the fourth one, you'll see there's an increase in volume because it said, hey, I'm not achieving what I actually need. So it's going to increase that volume. So when we start looking at waveforms, so the Hamilton T1 is actually going to be one of those things that these are things that you're going to be able to see. So you'll have a graphic display that you'll be able to look at as far as a graphic lung that you can see, and you'll be able to see resistance and compliance. You'll have a dedicated pressure waveform that you won't be able to change, but you'll also have other waveforms like flow and tidal volume that you'll be able to put up there. And the reason those are important to look at, besides just looking at a pressure waveform loop, is so that you can actually see what's occurring. So the first three lines on this one, pressure, that's something that you're always going to be able to see. So A is the initiation of my breath. As soon as I hit B, I'm now at peak inspiratory pressure. C is where I start and end. So this is where, remember we were talking about expiratory trigger sensitivity? So I'm going to trigger that breath now. So from this point to here is all inspiratory. So that valve, that expiratory valve, is basically closed until that point. So it allows for gas trapping, increased rate, asynchrony, all of those things to be occurring within that period of time. All the way over to D, that's your expiratory phase. So that's exactly when your exhalation valves are open, okay? So a volume waveform. So if you look at A, that's exactly what the patient is triggering. So they're dropping below baseline because they initiated that breath all on their own. So why do you think we need to actually look at like a pressure waveform? Does anybody know what delta P is? How about MAP, like mean airway pressure? Okay. So delta P is also considered amplitude, is basically the difference between PIP and PEEP. So you see this little slash line? That's called the area under the curve. okay, your mean airway pressure. The reason that's important, because when we're talking about like oxygenation and ventilating a patient's lungs, so all of this pressure, okay, in that area under the curve has an effect on the lung. So the longer that pressure is actually inside the lung, okay, the potential for damage is also there. So if I lengthen that time out, or I increase the amount of space between my inspiratory side, which we'll kind of get into, so I increase my peak inspiratory pressure, so now my delta peak tends to be higher, then you're going to increase that map. So, for example, you see the arrow. So these are two schematics. The first one, that patient is actually on 20 centimeters of water pressure. The bottom one, they're actually on 30. So what we did is, as we do that, if you notice, so the baseline peak pressure is about 3. So what we actually did is we increased that patient's time and pressure under the curve. So we gave them more pressure for a longer period of time. So what do you think that actually does? What does it do to our oxygenation?
Increases it.
Exactly. Why?
Because it gives the O2 longer to be in there for gas exchange.
Exactly. It increases FRC within the lung, okay, by doing so. At the same time, what other disadvantage could it be?
Increase interthoracic pressures.
Exactly.
Okay. What about damage? And because if I give too much pressure, am I gonna overshoot the lung by too much pressure and over distend it, its distensibility? Okay, so I'm gonna potentially rupture or cause an air leak because I gave them too much pressure now.
But you could also push out pulmonary edema too, right?
You could, exactly. But positive pressure is gonna, positive pressure on its own may decrease that on its own. In fact, if I just give a patient PEEP just by itself, or put them on CPAP, that may do that just by itself, because that positive pressure is just enough to decrease that resistance. Whether it be from a pulmonary vascular resistance standpoint, okay, or a cardiac standpoint. So, so the other thing that I actually increase that curve is time, whether it's on the inspiratory side or expiratory side. So if I increase my inspiratory time, so if I say, okay, I'm at 0.3, right? Now all of a sudden I take it to 0.5. Well, did I give that lung longer at that set pressure? I did. So I'm saying that that pressure is going to stay in the lung for a longer period of time. So I'm going to increase my mean airway pressure by doing so. Okay. If I shorten that, okay, what if I increase my PEEP?
It's going to raise your baseline up.
So does it raise my mean airway pressure by doing that?
Yes.
Yes.
Okay. Does it raise my delta P?
No, your pressure doesn't change.
Exactly. It won't change the delta P, but it will change your mean airway pressure, because it changes all that pressure under the curve because I just increased that. So the Hamiltons are adaptive. So if I set it at 15/5, you know, from a pressure standpoint, I actually have 20 centimeters of water pressure. So this is additive basically. So here we look at what we call variable flow patterns. No, this is actually isn't variable. I should apologize. So what we're going to look at, it is variable, but we're actually looking at a pressure control, pressure support type waveform. But what we're going to look at, and the bottom one, just so you know, the darker color is actually a ventilator on a patient. The top one's a schematic that we drew. So if I look at this patient, A on the top, so in the top waveform is actually a flow waveform. The bottom one underneath is an airway pressure waveform. So I inhale, boom, come to peak inspiratory pressure, where you try to almost see that peak pressure, but I should be peaking here, okay? Because of B, I've actually had too much flow going in, okay? So I'm overshooting that patient. So either my rise time is way too fast. So what do you think that this does to the lung when that happens? So do you think I'm getting all the ventilation that I actually should be getting, or am I over-ventilating that patient by doing that? That's exactly what you're doing. So I'm not actually So because of that, in fact, if you actually look at the slope on your flow coming down, you're actually noting, so most variable waveforms will always be a decelerating waveform, okay? So they'll decelerate to their baseline, okay? Unless you have peak there, and then it'll, be a little bit above that baseline, but that'll be your baseline. So as soon as I do that, and you notice on the flow, and the reason these are different is because I'm looking at two different flow patterns. One is a pressure, okay, and one's a flow itself. So they kind of tell you the same thing. So if I'm actually looking at a waveform versus a pressure volume loop, I actually will see this occur before I see my PIP increase potentially on my ventilator. So when I'm looking at that waveform, I can almost tell that that patient or what I'm doing with my settings, okay, are gonna make a difference. So how do you think that we could fix that?
Drop the pressures down.
You could increase PEEP, that might help. I could adjust my rise time, or I could adjust my flow rate. So we talked about variable flow rates and how it actually just kind of happens a little bit. So variable flow, okay, so I'm gonna drive the pressure in, come to a peak inspiratory pressure. As it starts to decelerate, here's actually where that valve is gonna close. So expiration is gonna start all the way back down to baseline. So this is where your FRC is actually at. So that functional residual capacity, you're coming to, that zero baseline. Then we have a continuous, something I did want to share with you. So a variable flow pattern is always, like I said, going to be either accelerating or decelerating waveform. So you'll always see that. Where your volume tends to be more square waved in patterns. So increased expiratory resistance. So why would I have that? What causes increased expiratory resistance in a patient?
Bronchospasm.
Bronchospasms. What about secretions? Okay. So on this type of patient, so if I have an asthmatic, okay, so my peak flow, okay, so, and even when I actually take that breath in, but as I exhale, it's a lot slower. And see how long it is? So it's kind of like that balloon, you're just letting out nice and easy. Rather than a pulmonary fibrosis patient or something like that just goes and they get it out real fast. So what do you think I could do to help that patient? So typically either suctioning, okay, or give them a bronchodilator. So what about gas trapping? You ever seen that happen when you've been on a transport or somewhere else? So how you're going to notice that typically, do they ever get to baseline? No, they don't, because their rate's so fast, okay, that they never come back up to baseline. So either they're going to trap gas in their lung, okay, so the next breath after that might either be the same volume or a larger volume or a smaller volume based on when that inspiration actually took place. But they're going to start, if I did an x-ray of this patient right here, I can guarantee you they're hyperinflation, okay? So one of the things that you could do is you could potentially increase the PEEP on this patient or the inspiratory time, and that might help lengthen them out a little bit, give them a little bit more longer exhalation time so that they kind of make that a little bit longer. Cycling mechanisms, so inspiratory time. So us as clinicians, we kind of really set that IE ratio. So we're the ones that set when the patient's going to take the breath in by their breath rate typically, or we'll set an I time. So we talked a little bit ago, so what's a typical I time for an adult? 1 second. What about a child? That's 3 to 8. About 0.5. Maybe a little bit longer, like 0.6 to 0.8.
Yeah.
You know, might be a little bit better. So the idea here is basically during the inspiratory pattern, so they're allowed to inhale during that whole time until that exhalation closes. So that's your whole inspiratory time. Once that expiratory valve opens, then everything is dumped out. So that's their expiratory time. So if you keep that real long, okay, you might shorten their time. So they're going to gas trap, they're going to become hyperinflated. What about flow cycling? So it's kind of just a natural tendency that we all have. Our lungs recoil just kind of like a slinky. So it just comes right back to normal baseline. So one of the things that we do though is we set on this is called ETS, okay? Expiratory trigger sensitivity versus, when our flow trigger sensitivity sets off. So you set this baseline based on that percentage. So typical, like we discussed, is about 25%. You can set it anywhere from 5 to 25%. And how it's based is that it looks, as soon as it gets to about, so what that means is as soon as it hits 25% of that peak inspiratory flow that's already dumped out, it's going to start closing the valve, and now the expiratory valve is open. So then expiration is going to start, and you should see it come right back up to baseline, hopefully. One of the things that actually does help is ventilator synchrony by keeping those triggers exactly where you need it to be. So, and you can adjust that a little bit by looking at your leak percentage. The Hamilton will actually show you a leak percentage, so you can somewhat use that as an additive to help you with that. Same thing with endotracheal tube leaks. So when am I going to see a leak on its own, typically, through an endotracheal tube? So infants, they're uncuffed tubes, so they're going to have leaks, no matter what. But, go ahead.
Well, no, actually, the infant Dragers, sometimes we have kids without leaks. But
And that's okay.
a lot. Yeah, a lot. You just want it below 50 to ventilate properly.
So typically if I'm going to see a leak, I'm going to see it during inspiratory pattern, right? Because my pressure's higher, right? So when I'm looking at a leak, so if you look at your airway pressure, I don't really see too many changes on that waveform, right? But look at your tidal volume. So I'm losing volume. And leaks can be small and they can be extremely large enough to where it doesn't know where to terminate, which will come to the next slide. So when I look at a large leak, so here's my inspiratory pattern, and all of a sudden I start my expiratory, but it doesn't know when to completely start the new cycle, because that leak is so large that it's just going to now go into a time cycling mode, which is exactly what your next slide is right there. On this one, so now it's all of a sudden go from triggering there to now triggering based on time, and it's still not going to come down to baseline. It looks like we have the patient on PEEP, but they're not. It's a large leak. So what can you kind of do to kind of help them a little bit?
There's mayor in the cup.
You can reposition them, and hopefully that'll help a lot. Sometimes, you might have to re-intubate them, but we try not to do that if we don't have to. So ventilator synchrony, just so you know, this is a patient that's actually on IMV, not SIMV, but they're kind of breathing around it. It's mainly the purpose to show you the difference a little bit. So obviously they're breathing on their own in between, breaths. So they're very asynchronous, taking as many breaths as they want. And that's not the way we try to ventilate patients typically. So you're going to want to at least make sure that you try to control your patient, whether it be by sedation. So ways to kind of treat this is basically put them in SIMV, give them some pressure support if you do have them in there, give them a little bit of support if that's what you have them on, if you know. So going back a few things here, it kind of brought me to this thing again, sorry. So when wouldn't I want to use an ASV on a patient?
It's like when their
Non-invasive.
lung isn't.
So there's some definite contraindications. One would be a bronchopulmonary fistula. Okay. Two is an extremely large leak.
Mm.
So if I have those two main things for sure, I definitely don't want to use ASV. Typically, on an infant, I'm not going to use ASV. Okay, so they're going to be probably your pressure control or lung control patients in the first place. At least for now. And just so you know, the draggers do have a mandatory minute ventilation, almost on the same concept that the Hamilton uses. So we could almost set one the same way as we're bringing a patient in. Now, it's not something that's typically used here too much, but Dr. Pantikar and Dr. Damon are both on gear for using the Hamilton, and they are aware. They've done some of the video just like you did, and they did ask for those classes, so they are aware of all the changes that's going to occur there. So basically, causes of problems associated with asynchrony, insufficient gas exchange, obviously the risk of increased leaks, okay, because the more pressure that's inside the lung, because they're either overventilating, okay, and it can't require anything, we're going to give them more sedation. We're going to prolong their ventilator time because we just caused an air leak or a pneumo. And basically, cerebral blood flow is going to be affected, typically more so towards the circle of Willis, and then IVHs. So here's a patient that's actually assisting a little bit. They're taking their own breaths. There is no pressure support on here, but if you notice the smaller breaths in between on an SIMV patient, so they're breathing just about 56 breaths a minute. So what would you do for that type of patient? Which breaths do you think are the machine breaths, and which breaths are
Well, the tall
the
one.
patient one?
The higher pressure is.
Okay.
I'd give them some pressure support.
Mm-hmm.
Cool.
That's exactly what I would do. Yes. So this is just a patient that's on assist control. However, they're not meeting their flow trigger in between. You can tell when they actually are assisting or trying to trigger the ventilator into a breath, but because they're not meeting that trigger, they're not meeting that breath. Okay. So why alter the mean airway, and what can we do to kind of change the pressure setting? So if I take my rise time and I change the slope of that, is that going to increase my pressure or decrease my pressure?
What did you do? Increase what you said?
Is it going to increase or decrease it? So this would be your rise time. Okay. So what about, and I kind of, diagram kind of gives it away a little bit. What about my peak inspiratory pressure, B? So is that going to increase my map, obviously?
Yes.
Yeah. Same thing, what about my inspiratory time, C?
Would be longer.
Because I'm giving that lung a little bit longer to be there. What about, and we answered this earlier, so I apologize, D, obviously if I increase my PEEP level. What about expiratory time? So if I shorten that time, does it affect my mean airway pressure? Does that make it easier or more or less?
More.
Why would it make me have more time in there? Because, so if I shorten my expiratory time, right, it's giving me more time in inspiration, right?
Right.
So that would be why it actually makes a difference.
I have a question.
You ask away.
Which factor will increase your MAP the most? Would it be you increasing your PIT, your PEEP, your rise time
They will all affect it the same way.
the same way? Okay.
They all affect MAP. The thing is you have to think of your lung compliance. What's your compliance of your lung actually doing, and how far do you actually want to distend that lung, and how do you want to distend it? So if I'm having more of a oxygenation problem, so obviously before I'd stick a patient on an oscillator, just as an example, you can manipulate your mean airway pressures on your ventilator to be able to try to keep as much of that PIP level and your mean airway pressure down. So if I increase my PEEP, right,
Right.
which has an effect obviously on my oxygenation, right?
Right.
So that itself is probably going to be the best thing to try to do. However, if I increase my slope, as long as I can keep my PIP down, as far as a rise time, that's going to be the other side that you probably want to manipulate rather than your PIP. Okay? But if you have a patient that you can't get the volumes that you want, you know, because you're not able to maintain, you know, the PIP's not doing the factor, okay, so it's not doing what you need it to do, then you're going to be probably increasing your PIP.
Gotcha.
You know, what your gas is telling you, what's your patient telling you. So, you know, they all have an effect on your mean airway pressure in that area under the curve. So they're all, especially the more that you put that lung at the distensible period of time that it's actually at its worst. So, for example, the dotted line actually works as what they call a compliance axis. So, what is compliance?
How easy the lung is to ride. And
So the definition of compliance is a change in volume over a change in pressure. So if I actually change and give 1 centimeter of water pressure, my volume should change by 1 centimeter of water pressure, which equals that slope of that axis by a 45-degree length. Okay? Once I start becoming more non-compliant, so my lungs getting stiffer, you're going to start seeing this compliance and this pressure volume curve dip down. Okay? So it's going to take more pressure to equal a certain amount of volume within the lung to actually ventilate them. Okay? The 2 dotted lines in the center, so here's your resistance. So as I have a bronchospasm, okay, for example, my airway is going to become really, really, really narrow. Okay, you can kind of see it a little bit more in that picture. So as it becomes more narrow, I might want to give them a bronchodilator to try to open them up. Okay. So just for example, this patient here, they actually were given a bronchodilator. It actually increased their lung volume 150 cc's. So they went from, as you can see in this picture over here, 308 cc's to 458. So it actually also took less pressure to ventilate them. If you look at the lower slide, okay, my peak inspiratory pressure is past 20. If you look at the top, it's about 19. So not only did I increase their improve their compliance, but I also allowed their airway to be a little bit less resistant. So a lot of times some ventilators use basically volume targeted or pressure targeted ventilation. So tell me what pressure targeted ventilation would be.
Targeting certain pressures within the.
So I can get a certain volume based off of a targeted tidal volume, right? Or a targeted pressure, right? So, and the opposite for pressure targeting. So if I say, here's 20 centimeters of water pressure, right? I expect to achieve 400 cc's of volume, okay? You're in volume targeted, basically ventilation. So I should try to achieve that volume based on that pressure target. Okay, so I set that pressure to achieve that volume. The opposite is true for volume targeting. I meant for pressure targeting. So I set a volume and allow the ventilator to set my pressure. And your lung compliance model is going to change based on that. A lot of ventilators will utilize, in fact, this one kind of does exactly that. in ASV. It's going to consistently look at that compliant model, okay, and whether the lung compliance is improving, getting worse, okay, or you have an extremely, asthmatic patient that they're just got tons of air in their chest, okay. So when a lung itself approaches what we call its distensibility period, so where it's basically at maximum volume, okay, so we've already distensed the lung towards past FRC, okay. There's a model called C20, and actually the draggers do this over compliance. And if I give a patient 20 centimeters of water pressure to achieve a volume of 190 cc's, and I'm just throwing that out there, but yet now because I've given them too much pressure, now all of a sudden that slope starts to look like a duckbill. Well, that tells me that I'm going past what they're called closing capacity of their lung. So closing capacity happens at the point in the smaller airways, okay, just before they close. So that means that we're past the point of FRC, which means that's not really where I want to be with my ventilation. So when I start causing more harm by giving too much pressure, okay, then you're not actually going to want to distend that. So you have what they call inflection points. So you have a lower inflection point and you have a higher inflection point. So when we start looking at how bad a patient's lung volume or compliance is, I'm going to start looking at their inflection points. Now I know you guys won't be able to see that on your monitor, but the concept is that when I look at that pressure waveform that you talked about earlier, and you look at a pressure overshoot, because I've given too much pressure, you'll be able to see what you're doing because you're giving too much pressure before even looking at this. Because once my slope starts to turn, then I'm actually doing the damage to the patient's lung, not the other way around. It's not because of pneumonia or ARDS that their compliance has gotten worse. It's because I've increased the pressure, and now I've distended that lung and causing basically rupture or air leaks. So, and typically in children, by the way, you don't want to go past the closing point of their lung, because once you do, it's hard to get those little alveolar sacs back open, especially in infants, especially if they're lacking surfactant. So lung compliance in itself basically is a measure of the lung's ability to stretch and expand. It's stability basically of elastic tissue. So change in volume divided by a change in pressure. Separated into 2 points. Static lung compliance, which you guys will be able to see. And as you'll learn here when we do the next little section, there's actually a section where you'll be able to do an inspiratory hold, and you can actually see what your static pressure is actually doing, and it'll actually tell you under monitoring what you'll see. Compliance basically on normal value is 60 to 100 measured during periods of gas flow. So that means gas flow comes to a halt, okay, during an inspiratory pause. So there's no movement of air in the lung at that period of time. That's why you give them an inspiratory pause. Dynamic compliance is basically the lung at any given time during actual movement of air, okay? It's calculation basically the corrected tidal volume divided by your PIP and minus your P. Static lung compliance is basically your corrected tidal volume, okay? Plateau minus your P. Typically about 3 to 5 centimeters below, okay, your PIP value, okay, when airway resistance basically. So if I had airway resistance, where would my static compliance go? Would it be higher or lower?
Lower, higher air resistance. There'd be a bigger
So-
difference between your plateau pressure and your PIP.
And your PIP. So, increased airway resistance. PIP increases, plateau pressure remains the same. So that, because it's basically just resistance. It's not the compliance of the lung that's actually changing. It's just the resistance in the tubing, okay, and the way we ventilate. These two, so on the Hamilton T1s, so you have a coaxial tubing, which is a very compressible tubing, so when it looks at corrected tidal volume, when you set the tidal volume in there, it all corrects it based on the compressible volume of the tubing that you're gonna ventilate the patient with. For an infant circuit, it is the same, but they're both really actually dual limb circuits. But the coaxial just has the blue line, which is your inspiratory line within the white kind of compressible circuit. So airway resistance can be estimated by your PIP minus your plateau pressure, as well as divided by what we call your flow, and that'll give you your airway resistance. Common causes obviously are secretions in the airway or bronchospasms, so suctioning your patient or giving a bronchodilator will actually improve that. Decreased lung compliance, so your PIP now increases as well as your plateau pressure because that compliance now changes. So it's either gotten stiffer, okay, because I've went into ARDS, atelectasis, or pneumonia. So obviously increasing my PEEP, and hopefully just treating the underlying cause will treat the problem, you know. And the guideline, like the reason I think we kind of put 6 mils in there per kilogram is because, you know, between ARDSNet, you know, treating ARDS and acute lung injury, and the pediatric guidelines that are now developed for treating acute lung injury and ARDS are out. And so a lot of that small volume, you know, faster rates are things that we're going to start ventilating patients with rather than those big, nice, let's give them 1,000 cc tidal volume and say, oh, here you go, we can manage your gases this way. So, and that doesn't really work. And obviously emphysema being, you know, a patient that's going to have a very large compliance, right? So on your Hamilton T1s, you are going to have this little picture a little bit, but it represents kind of the lung. It's actually your dynamic lung compliance. So normal range being, you know, plus or minus 20%. You see nice rounded lungs there. There's no red indicators. And on the Hamilton, it'll be like blue highlighted. And as that compliance starts getting worse, okay, so it actually starts getting like bigger, you know, and whoosh, right? So now when my lung compliance, as you see here, that turns red, it starts getting darker and darker and darker as that compliance starts getting worse. And then a resistant factor that you'll see on, which it's not on the slide, that you'll see actually on the Hamiltons is as that resistance increases, so you won't have to tell the difference between resistance and compliance on there. All your bronchoalveolar airways will start becoming darker as that airway resistance increases. So that dynamic compliance module actually gives you a good indicator of what you're actually going to see. So, any questions? I know that was a lot of stuff for you guys. Probably would